Over the next two sketches, we're going to be covering congenital heart disease. These abnormalities of the heart or great vessels usually arise from faulty embryogenesis during the 3rd through 8th weeks of gestation. They range from severe pathologies incompatible with life to mild anomalies with only minimal symptoms at birth that can even go unrecognized throughout life. These structural abnormalities can be divided into two major groups: malformations that cause left to right shunting of blood, and malformations that cause right to left shunting of blood. Babies with right to left shunts are going to be cyanotic at birth. These are your blue babies. Deoxygenated blood from your right heart mixes with the oxygenated blood in your left heart, and it's sent into the circulation. That's for our next video, however, which takes place at a manga convention. Why manga, you ask? Manga is read in the traditional Japanese style, from right to left, of course. In this sketch, however, we're going to cover left to right shunts, which include VSD, ASD, and PDA. Now, I couldn't tell you the difference between a Deadpool and a Deathstroke, or an Aquaman and a Submariner, but I'm pretty sure comics are read from left to right. So sharpen that adamantium and get out your best spandex onesie, because we're headed to the comic convention, baby. With the left to right shunts, there's an abnormal communication between the left and right sides of the heart. Take a look at this comic book stand here. I want you to imagine the patient's left and right heart chambers. The blood coming into the left has just been oxygenated in the lungs, and therefore the O2 sat is normally around 95%. The blood in the right side of the heart has just come from the body and sits at about 75%. Because of higher pressure on the left side, blood shoots over to the right side through a defect. What results is a measurably increased oxygen content inside that right chamber, usually around an 80% O2 sat. On test day, look out for that right-sided chamber that seems abnormally oxygenated. That's where the defect is. Right atrium is at 80%. That's an atrial septal defect, shooting oxygenated blood over to that right atrium. Right atrium is at 75%, but the right ventricle is at 80%. That's a ventricular septal defect. Right heart chambers are both at 75%, but the pulmonary artery is at 80%. This one's a bit different. That's a patent ductus arteriosus, and we'll get to that in a little bit. All right, remember, right to left shunts are your blue babies. These defects will be covered in the next video. Newborns with left to right shunts, on the other hand, are usually acyanotic at birth. So, pink babies. They don't always stay that way, though. In adolescence, these left to right shunts can reverse and become right to left shunts. This is called Eisenmenger syndrome, embodied by Dr. Eisenmenger here. What? You haven't seen it yet? It's only the best movie of the summer. The story goes like this. In left to right shunts, all that blood is getting dumped into the right side of the heart, and after a while, the right side just can't take it anymore. See that eerie cat's cradle Dr. Eisenmenger uses to manipulate the universe's ambient magical energy? That represents tension on those pulmonary arteries. Spoiler alert, but that extra right-sided flow leads to pulmonary hypertension. The pressure on the right side of the heart now becomes greater than the left side of the heart, and the shunt reverses. Clinically, this presents as cyanosis, hence Dr. Eisenmenger's reversed cyanotic alter ego. In order to avoid this fate, surgical intervention is required early. It's important to remember that this late-onset cyanosis and shunt reversal only occurs if the ASD, VSD, or PDA is large enough. Small left-to-right shunts will not typically develop Eisenmenger syndrome. All right, let's start getting into the specifics of each pathology, starting with ventricular septal defect, or VSD. It's Victory Man! The vast majority of VSDs occur in the membranous region of the ventricular septum. That's the thinnest, most superior portion of the septum. So we've made our V-Man cosplayer here, opening up the top of his jacket to expose the VSD. The inferior muscular portion of the septum remains buttoned and intact. Luckily, most VSDs close on their own in childhood. So while there are a lot of babies born with VSDs, there aren't a lot of adults with VSDs. When the VSD is small, you'll likely hear a loud, blowing, holosystolic murmur at the left lower sternal border. This murmur is not picked up at birth. Instead, you'll hear it around 4 to 10 days after delivery. A small VSD is embodied here by the small, scrawny Victory Man cosplayer, getting socked in the lower sternum. Nerd. Remember, whenever we want to convey clinical events that occur during systole, like a systolic murmur, just look for that systolic spray. So the murmur occurs between S1 and S2. Hear it? Because it's hollow systolic, we've made him dropping a comic book with a cool hologram on the front. Wait, holy frack, a first edition Victory Man with limited issue hologram cover? Why isn't that in its Mylar? All right, one more thing about the murmur. Any maneuver that increases afterload will send more blood through the VSD from the left ventricle to the right, causing an even louder murmur. You can do this with a hand grip maneuver, for example, which increases systemic vascular resistance, hence this bully's violent hand grip maneuver that evokes a murmur from this poor little V-man. Also, if the VSD is small, the baby will probably be asymptomatic. So next to the small, scrawny V-man, we've drawn in a happy little pink baby being protected from the bully. She'll be just fine. If the VSD is large, however, it can present as heart failure, failure to thrive, and diaphoresis with feeding. So notice that our larger, overzealous V-man has toppled over a stroller. Definitely some feeding issues in store for that little guy. Also, that little volume-overloaded failing heart is represented by a recurring, floppy failing heart balloon. Turns out that a really large VSD might not even have a murmur associated with it because the pressures between the left and right ventricle equalize due to the communication being so big. Large VSDs will not close on their own and must be closed early with surgery to avoid sequela. All right, let's head over to the atrium, where we'll introduce the next congenital heart pathology, atrial septal defect, or ASD. Before we get into the clinical presentation, though, let's go over how these lesions occur. This is going to involve some embryology. Okay, sorry. Didn't know that word was taboo around here. Just hear me out, okay? We'll keep it simple. The first septum formed between the left and right atria is called the septum primum, and in this sketch, it's represented by the first set of doors that the visitors must walk through before entering the atrium of this convention center. There are two holes, or ostia, that form in this first septum, the ostium primum and ostium secundum. The ostium primum eventually closes on its own. See that sign, though? It's the second hole, the ostium secundum, that stays open. Now it's time for the second septum to grow in, the septum secundum. It's depicted by the cool, futuristic sliding doors here, installed just for the comic book convention. The septum secundum usually grows in next, to cover up the ostium secundum. But take a look at little Bruce Banner here. About 90% of ASDs occur when the septum doesn't form fully to cover the hole. Notice that we can now see directly through, all the way outside. There's now direct communication between the two atria. ASDs are usually asymptomatic until adulthood, but unlike VSDs, ASDs rarely close on their own. His secret? He's always angry. I want to take a minute to contrast this condition with what's called a patent foramen ovale, or PFO. Take a look at the other entrance in the back. We've got our main doors, the septum primum with an ostium secundum, and like before, the septum secundum, those sliding doors, grow in front to cover the hole. This time, however, the septum secundum has grown all the way across. See how we can't see through to the outside anymore? There's a little oval-shaped hole left in that second septum, though. That's called the foramen ovale. It normally stays open during fetal development. Imagine blood flowing through the foramen ovale, kind of squeezing through, and then flowing through the ostium secundum out to the left side of the heart. When the baby is born, the pressure on the left side of the heart presses those two membranes together, the septum primum door and the septum secundum door, causing these two layers to fuse. Well, that's what usually happens. Turns out, in about 25% of people, this patent foramen ovale stays open. This incomplete fusion sign should remind you of the lack of membrane fusion that keeps the foramen patent. The PFO acts kind of like a valve. With pressures high enough in the left atrium, these membranes get pressed together anyways, and there usually isn't much flow through the foramen. In ASD, on the other hand, there is flow with every atrial contraction, usually from the high-pressure left side to the low-pressure right side. Every once in a while, however, the flow can reverse, going from right to left. And this is the perfect opportunity for a little embolism from who knows where to sneak across and cause a stroke. Pew, pew, pew! See how Astro Girl here sends little emboli through the ASD straight to the head of each unsuspecting visitor? Cryptogenic stroke, also called a paradoxical embolism, is a test writer favorite. They'll describe a vignette where a young adult has a stroke. In other words, not that old vascular patient you'd expect, and they'll ask you what congenital heart defect the patient was likely born with. The answer is either an atrial septal defect or a patent foramen ovale. Flow from the right atrium to the left atrium can occur when those right atrial pressures get abnormally high for just a split second. This occurs during straining or valsalva, like during a sneeze, for example. And that's why we've drawn Mini Hulk straining to keep that door open. PFOs are much more prevalent than ASDs, remember. So in a patient with suspected cryptogenic stroke, you'll most likely find a patent foramen ovale. Explains the low turnout, I guess. One of the ways to spot an atrial septal defect is by auscultation. Whip out that stethoscope and take a listen. It's between S1 and S2. You hear that? Because it's a systolic murmur, we've added a new attachment to Astro Girl's arm cannon, that systolic spray nozzle. An ASD is also associated with a wide, fixed splitting of the S2 heart sound. Hear that lub-dub-dub instead of lub-dub? If you listen to a normal heart, you may hear the S2 split during inspiration, but return to a single S2 during exhalation. Fixed splitting of the ASD murmur just means that it's always present. Let this mom here represent wide fixed splitting as she keeps these cosplaying twin sisters widely split apart. Another little buzzword they might tack on is what's called a diastolic rumble, a low-pitched rumble heard after S1 and S2 due to a greater than normal flow across the tricuspid valve. Take a close look at the cover of the newest issue of Astro Girl. The scene takes place in the diastolic diamond cave. And I definitely see some rumbling there. All right, to sum up, ASDs produce a systolic murmur with a wide fixed splitting of S2 and a diastolic rumble. Now, this is not due to flow through the ASD. ASD leads to some left chamber blood entering the right chamber, so the right side is volume overloaded, and all this increased flow through the pulmonary valve is heard as a murmur. We tried to emphasize this by making the right side of the mom soaked and obviously fluid overloaded. Besides auscultation, ASDs are usually spotted on cardiac echo. In contrast to a true ASD, a patent foramen ovale does not produce a murmur. In order to detect it, cardiologists must do a bubble study where they inject agitated saline intravenously and watch on an echocardiogram as the patient releases a Valsalva maneuver. Remember that Valsalva can reverse flow and send blood between the atria. You should see those bubbles getting through as well. The last of the left to right shunts is what's called a patent ductus arteriosus, or PDA. This occurs when the ductus arteriosus, which is open during fetal development, doesn't close like it's supposed to after birth. Our recurring sketchy symbol for ductus arteriosus is an air ductus, like the one here, near the ceiling of the convention center. See this robot in disguise here? That big ruby in the center of his chest should remind you of a rubella infection. Rubella can cause a congenital syndrome that includes a patent ductus arteriosus. PDA is also more common in preterm infants. During gestation, the placenta produces prostaglandin E2, which keeps the DA open. Just like ductus prime here, keeping that duct open as he wields that prostaglandin pro-slugger bat. After birth, there's a rapid decrease of prostaglandins reaching the baby, and the ductus arteriosus closes in 1 to 2 days. If PDA is the only defect present, administration of indomethacin should be enough to close it. Because indomethacin is an NSAID, it blocks prostaglandin production. And as usual, it's represented by our anti-inflammatory NSAID fire extinguisher. However, and this is an important point, a PDA can be life-saving if another congenital heart defect is present. This is particularly true for the right to left shunts we'll introduce in our next sketch. A PDA may be detected on cardiac auscultation as a continuous, machine-like murmur. Know what I mean? Continuous means that it's heard during systole and diastole. It's also associated with a widened pulse pressure. In other words, instead of measuring 120/80, it'll be something like 120/60. This increased distance between high and low pressures is embodied by ductus prime, as he flexes his pulse pressure and separates that slab of concrete from the ground below. Take a close look, because there's more than meets the eye here. If the PDA remains open and progresses to Eisenmenger's, the cyanosis will be in the lower extremities only. This is because deoxygenated blood is being delivered distal to the left subclavian artery. Therefore, the upper body will be pink while the lower body is blue from cyanosis. I want to wrap up this sketch with coarctation of the aorta. Now, this is not a left to right shunt like the others, but we added coarctation to the scene because it's a congenital vascular defect that can present like PDA, with lower extremity cyanosis. I'll get to that in a little bit. First, some background. Coarctation of the aorta involves a narrowing of the descending aorta that occurs near the insertion of the ductus arteriosus. See that rainbow or colorful arc in the back? That's our symbol for coarctation. And it looks like we've got a rogue cosplayer up there who's somehow managed to climb that aortic pipe, causing a constriction right near that air ductus. It's obviously her first comic convention. I mean, did she just throw in an old Halloween costume? Maybe she was going for Scarlet Witch? Either way, take a look at that little whirly windmill toy. Let that turning windmill remind you of Turner syndrome, a developmental disorder associated with short stature, webbed neck, a broad chest, and other specific cardiac and renal malformations. These girls are monosomy X, so they're missing that second sex chromosome, which is also symbolized here by the single X-shaped windmill sail. It turns out that congenital aortic coarctation occurs in up to 10% of patients with Turner syndrome. Aortic coarctation is also associated with what's called bicuspid aortic valve. Take a close look at the mouth of that horse puppet. The nose and lower lip kind of open to form two cusps. See? Well, the aortic valve is normally composed of 3 cusps, but in about 1 to 2% of live births, an anomaly leads to right and left cusp fusion, and you're left with only 2. And trust me on this, it looks just like the mouth of a hand puppet. Bicuspid aortic valves like to calcify early, which is why the horse has those calcific white spots, but we'll get to that more in a later video. The signs and symptoms of aortic coarctation depend on the age at presentation, which varies according to the severity of the stenosis. If the stenosis is severe, it will most likely present in infancy. Look out for differential cyanosis affecting the lower extremities, hence the pink top and blue cyanotic leggings. These patients rely on that ductus arteriosus to stay open and help carry blood past the coarctation. When the duct closes, however, these neonates will develop signs of heart failure and shock, as embodied by a recurring floppy heart failure balloon, floating right above that closed duct. More moderate stenosis often presents in childhood or adolescence, so compare our infantile cosplayer with the adolescent convention employee to the right. With the section of the aorta constricted, just distal to the origin of the left subclavian, it's not hard to imagine a significantly increased blood pressure in all the vessels before the stricture. This usually includes the upper extremities. I mean, just look at that steam. He's right, you know. The descending aorta is not a jungle gym, young lady. Coarctation patients can develop numerous complications related to hypertension. Let's see. There's left ventricle hypertrophy and failure. There's aortic dilation with increased risk of dissection. Just look at that pipe. It's about to split open. And what about intracranial hemorrhage? This is due to formation of baryaneurysms in the circle of Willis because of an increased cerebral blood flow. See that red stroke of paint? That's hemorrhagic stroke, my friend. The lower extremities don't fare well either. You see, coarctation may eventually lead to a measurable blood pressure discrepancy between the upper and lower extremities. Just look at where he's grabbing onto that pipe. High pressure above, low pressure below. You may also notice delayed or diminished lower extremity pulses. This is represented by the numerous delays in the lower half of the convention schedule. Reduced circulation past the area of coarctation can even lead to symptoms of lower extremity claudication. In other words, pain and cramping with exercise due to ischemia. Hence the black ischemic paint all over his pants. Over time, collateral circulation can develop to help divert blood flow around the area of coarctation. The subclavians, remember, usually branch before the stricture, and so they're getting plenty of oxygenated blood. Well, let's take a quick detour. Instead of squeezing through that coarcted aorta, what if we go up through the subclavians? Then down in the back of the sternum through the internal thoracic arteries, and then into the anterior intercostal arteries under each rib. These feed the posterior intercostal arteries, which then flow back into the aorta. And there you have it. We've bypassed the coarctation. Strangely enough, this can be picked up on chest X-ray. The intercostal arteries become enlarged and deform the ribs, which appears as inferior rib notching on the X-ray, kind of like the notched ribs of this ladder. All right, let's wrap up this sketch with a brief discussion of infective endocarditis. At Sketchy, endocarditis is represented by a flame coming from within, kind of like the heart-shaped lantern there. It turns out that approximately 3/4 of patients with infective endocarditis have a pre-existing structural cardiac abnormality. Imagine a weird stream of blood damaging that endocardial surface, leading to a nidus for bacterial growth. Well, there are numerous congenital heart lesions that predispose patients to infective endocarditis. This includes many of the pathologies covered in this sketch: ventricular septal defect, patent ductus arteriosus, coarctation of the aorta, and even bicuspid aortic valve. Remember that bicuspid hand puppet? You may have noticed that I didn't mention ASD. It turns out that the pressure differential between the left atrium and the right atrium is just not that significant, and therefore the endocardium isn't prone to the same kind of hemodynamic injury that can occur with other defects. Take a close look at the cover of the Astro Girl comic, and you may even notice that we've included that gross endocarditis monster right there on the cover. Psh, he's no match for Astro Girl. Infective endocarditis? Not on my watch. Oh, shoot. The Captain Canuck conference is about to start. All right, we have to wrap this up, you guys. I have hours of waiting in line to do. Let's see here. To sum up the sketch, I'd like to reiterate that VSD, ASD, and PDA are left to right shunts. These are your pink babies. Cyanosis develops later, in adolescence. When they do turn blue, it's due to pulmonary hypertension reversing the shunt. Dr. Eisenmenger strikes again. Also, remember your murmurs. PDA will give you that continuous machine-like murmur. ASD often shows up as a systolic murmur, hence the systolic spray, with the widely fixed S2 split, which is why the sisters are split. They might also throw in a diastolic rumble or two. Thirdly, there's VSD. Listen for a hollow systolic murmur when it's small, and probably no murmur when it's large. Large VSDs are more likely to manifest as failure to thrive and heart failure in the newborn. Just take a look at that stroller toppling over. A comic convention is no place for babies. With ASD and PFO on the right there, watch out for cryptogenic strokes sneaking through. And lastly, while both PDA and coarctation can show up with differential cyanosis of the lower extremities, coarctation will also manifest with a few more pressure symptoms, especially when it shows up in adolescence. Look out for high pressures up top and low pressures down low. You might also detect delayed pulses to the lower extremities. On test day, focus on the age of the patient that is presented in the vignette. If the question begins with a 7-year-old with or without cyanosis, your differential should focus on a left to right shunt. If, on the other hand, the question starts out with a blue neonate or 2-month-old, now we're talking right to left shunts. And for those, pack your bags because we're heading to Japan.